organizing committee for this really kind invitation to participate in this monumental event. I look around the room, and this is really a testament to you, Tirone. And I think most of us could only dream to have a fraction of the impact that you've had on our specialty. So thank you for everything that you've done for us, and thank you for everything that you continue to do to push us forward. So I've been tasked to speak, where's the clicker? Oh. About artificial chordae. This screen is huge. Okay. So these are my disclosures. So, Tirone was the first to use Gore-Tex Neochordae, and he described it back in 89, but I think his first case was back in 85. And he described using 22 patients, and he described multiple techniques of chordal reinforcement, replacement, and shortening. And he had very nice results, and the majority of cases were for anterior leaflet disease. And he reported 750 patients several years later, where he had 10 years of follow-up and showed excellent outcomes with a very low reoperation rate and very low recurrent mitral regurgitation. And the technique that he really refined was this multiple interdependent neochords with one single suture, which he showed us earlier today. And, neochords is a little bit like going to Starbucks. We all like to use it, but we all have different ways, and we have slightly different variations on how we use it. And, the reason why I like to use it is because, it's a simple technique. It really is, it's well suited to many different types of multi-segment prolapse, anterior, posterior, commissural, bileaflet. It maximizes coaptation surface, and you get greater heights of coaptation. You have low gradients, and it's associated with very durable repairs, excellent outcomes. And so let me show you a video here. This is a 45-year-old male with bileaflet flail. And, I like to use Neochordae loop technique that I learned when I was a fellow with Fred Moore in Leipzig and Michael Borger. And so here you can see, it's very simple. You have a fixed length, you attach it to the appropriate papillary head, and then I actually preload my loops with an extra Gore-Tex so that you don't have to reach down in to find it again, and it makes it very simple to be able to attach it to the free margin. And so here you can see the posterior. I always, as I think Pat McCarthy had mentioned earlier, I always do the posterior first and then go to the anterior after. And here you can see the anterior flail. And so two separate sets. It's a very simple sort of solution to a more complicated problem. Here you can see the sort of result. You see a nice height of coaptation of over 1 centimeter and nice low gradients. There are some simple rules with the Neochordae loop technique. Don't cross the midline. Keep with anterior to the anterior papillary muscle. Try not to disrupt any native chords, and see if you can find many times you can find the base of where the ruptured chord was. The other thing that's really nice with the Neochordae loop technique is that it's very easy to adjust to try and optimize your coaptation. And so here you can see in this example, this is a 56-year-old with a very straightforward standard flail P2 segment. What you can see here is I like to identify where I'm going to place the neochords, and I use a marker just to mark down to help with teaching the residents and fellows where to place those, and those would also be similarly the same width that you would do your resection if you're going to do that. And then after that, similarly to what you saw before, place my neochords into the papillary head and such that the neochords will come out centrally so that it won't disrupt or cause any problems with any of the other native chords through the center of the lumen. And then attach all the loops, again, preloaded so that there's no mix-up in the order, no twisting, and you can just attach it to the free margin quite easily. And then tie it down. So, you don't have to fuss with foreshortening your neochords too much or having a problem because of that. And once you've tied it down, then you can place your annuloplasty sutures and then do your saline test. And on the saline test here, what I wanted to show was that what you see is a little bit of an imperfect result. And so what you'll see here in a moment is on the saline test is that there's a little bit of residual leak on the saline test. Now, it's not perfect because it's obviously not under normal loading conditions, but what it suggested to me is that I actually placed my most lateral neochord a little bit too far lateral, a little bit too close to the medial, to the lateral aspect of P2, causing a tiny bit of restriction, and you can see a little bit of residual jet there. And so it's a simple maneuver, just detach the most lateral loop and then move it a little bit more medial. And with that, here you can see, moving that loop a little bit more medial resolves the problem completely. And so it's a very simple fix, without having any sort of having to extend a resection or anything of that sort. Next, here's an example with a bileaflet prolapse with a Barlow's patient. This is a 36-year-old female. And one of the things I want to highlight is that I rely 100% on the TE to make my plan for the repair. And the TE should be able to, as David had shown earlier, should be able to show you everything you need to know about your plan for the repair. I think it's equally, and if not more important, to do the segmental analysis on the TE than to do your intra-op analysis. And when I have very wide prolapsing segments or flail segments, I think it's a very good technique to use neochords. When it's very narrow, it makes it quite easy for a triangular resection on the posterior leaflet. And so here you can see this is prolapse in every segment. And in this sort of scenario, I know it's a little controversial, but I think it's very useful to use neochords on all the segments. And so what I've done here is I've placed, I've divided the valve into quadrants, because when you use Neochordae loops, it's better to divide into quadrants than the standard Carpentier 6 segments. And I placed 14 Neochordae loops, 8 posteriorly, 6 anteriorly, and with that you can see that you get a very nice repair result. The most important thing when we repair these valves is durability. And let me just show you an example. This is a 75-year-old that back in 2008 had anterior leaflet flail with some LV dysfunction. And so here's the video from it. And so similarly, Neochordae was really optimally designed for the anterior leaflet. And so here you can see placing some anterior Neochordae loops to the anterior head of the posterior medial palpebral muscle, and then fanning out these loops to attach, 3 loops to attach to A2. And one of the things is that you can oftentimes get a good early result, but it's the long-term durability that people will suggest, that might be compromised when you use neochords. But, this is where one of the things that Tirone always reinforced to me, he said, you got to follow your patients. You got to follow your patients. How are you going to know if you're going to make your operation better if you don't follow your patients? And so, I took that to heart. And so here you can see, well, here's the 1-year result. Well, what happens long term? Because it's the long term that matters. So you follow them out with the same echo lab at 5 years and 9 years, and you can see that your repair is durable. The neochords, you can barely identify them, and in many cases they've endothelialized. And so I feel confident that this sort of repair strategy is quite effective. And as a result, much of my practice for repair of degenerative disease involves neochord in almost 85 to 90% of the cases. And when I followed these patients out to almost a decade, I found that there's a high freedom from recurrent MR and excellent long-term survival. Now, many of us have been to many meetings when you see that there's a camp that gets drawn where it's like neochords versus resection. And you see on the neochord side, it tends to be the descendants of Fred Moore and his group. And on the other side, you see a more traditional conventional method where resection with the individuals having a certain phenotype. On the neochord side, usually the argument's made, well, it's an easy way to repair the valve, it's a simple way, and it's applicable to most patients with many types of degenerative disease. Additionally, people say, well, if you're wrong with your neochord, you can easily take it out and do something different. On the resection side, it's a little bit more nuanced. What you saw earlier with Dr. Adams, you see very complex repairs, and oftentimes it comes from very experienced teams. And the thing is, it's not really a competitive sort of thing. I think neochords and resection techniques are not mutually exclusive. We need to have a more balanced approach. When we can select using each approach for each patient, whichever we think is going to get the most durable result. I can't control this video, so I apologize. I'm going to skip over it. But basically, what I'm showing in this video is that using a combination of resection and neochords can yield a very nice result. There are pitfalls to Neochordae reconstruction. You can cause contralateral leaflet foreshortening, crossing the midline. You can have inaccurate lengths. One of the big problems with inexperienced mitral repair teams is that they leave the coaptation zone too anterior when they have neochords, and they can run into problems with that. And one of the things I want to highlight is that an absence of MR on saline test does not mean you're going to have a durable repair. And so I think we can do a better job at trying to get better at our repairs. And I just show a couple examples quickly of failed repairs. One of the advantages with neochords is if a patient's had a neochord repair and it doesn't work, you can always, many of these cases are easily re-repairable because you take down the neochords and then you can convert the patient, for example, in this case, to a resection and have a nice result. And here's another case here where you actually see the neochords that the surgeon had implanted on the top right-hand side are still working, but the surgeon had missed the more medial aspect of the valve where you see residual prolapse and unfortunately developed severe MR and hemolysis. And all it took was to take the patient back for a simple additional triangular resection and with quite a successful sort of result. In terms of the posterior leaflet durability, I can just highlight here again with the same principles. This is a patient that I did 15 years ago where you can see that the repair at 5 years, at 10 years, and at 15 years still remains durable. And you can see that the neochords continue to function well, extremely well. And so, I have very little concerns about the durability of it. The last two things I'll just mention briefly is that there are ways. In London, we've created a simulator here to show you that you can use a patient-specific 3D printed model. Can you advance? I apologize. Oh, okay. You can use different ways, and so what I was going to show you, we have 3D printed models to be able to repair the valves, and you can try with neochords or with resection before you actually do the operation. The other thing which we just presented at AATS was using AI and machine learning, and we have some exciting projects on the future on the horizon for that. So I'll stop there. Thank you very much.